I'll pick up where we left off here and talk a little bit. I'm a cardiologist, so maybe from a slightly different perspective, but talking about the utility of this test and some of the management issues that we face. So as we already heard, brachial artery blood pressure is not always exactly what's represented in the central pressure, especially if we have stiff arteries. We see a lot of vascular calcification, especially among our dialysis patients, and we sometimes have a misrepresentation. So we know that as central pulse pressure increases, we have an increased risk of stroke, renal failure. We'll talk about LVH and even heart failure as consequences of direct organ damage from this central pressure. Now this slide, I think, nicely demonstrates that overall, statistically, right, so as an epidemiologist, I look at this and I go, oh, that's a pretty good correlation, right? I got central pressure on the left, I've got brachial pressure on my x-axis, and I can see here a very good overall correlation between the two. But for any given point, there's a pretty wide variability. It's about 30 points. So I can have a patient who has a brachial pressure of 150, and they can have a central pressure of 120. Much different, right? Pretty normal blood pressure, even though their brachial is reflecting high. Or I can look at it the other way. I could take a patient who has a peripheral pressure that's high and have a central pressure that's also high. So I don't always get the right answer from my brachial artery. I can be off by 30 millimeters of mercury. And we all understand that. When we see patients monitored in the intensive care unit, sometimes we put in central lines, and the art line and the peripheral blood pressure don't line up that well. So these are the type of patients we're trying to tease out. These are the type of patients that are going to have implications for central organ damage. The brain, the kidneys, the heart are going to be affected by a differential pressure than what we may be measuring in the brachial artery. So I'm not advocating that we put in arterial lines in everybody, but I think we can accurately derive the central pressure. Now this was already demonstrated, so I think this was shown nicely already, the natural progression of what happens over time. But when we start getting a taller peak, that's going to be more workload on the heart. So that's going to be a reflection back on the heart, as we heard, and that's going to cause more left ventricular hypertrophy, more left ventricular mass. We start losing the diastolic reflection as the central pressure goes higher. We start losing diastolic filling. That's when the coronaries fill. So that's going to put us at risk for things like coronary artery events, and of course myocardial ischemia. So this is going from a nice healthy young person, the pressure starts going up, then it starts getting wider and wider, and eventually we have a very wide diffuse pressure that's going to affect myocardial ischemia and cause central organ damage. So a simple pathway here that demonstrates the central blood pressure changes over time. Now here we can see this is two different scenarios here, two different patients here. This person in red has a brachial pressure that's 144 and a central pressure that's also very high. This person in blue has a brachial pressure of 144 and a central pressure that's very normal. So the difference here can be seen by the waveform, but when we take a blood pressure with a cuff, we don't get a waveform. So I can't tell, I can say, okay, 140 over 90 for both of these patients, but that doesn't adequately reflect what's really going on, right? We heard about how this broad-based picture reflects more reflection back to the heart, more pulse wave velocity, higher pulse wave velocities, and more central aortic pressure. That's reflected here by a much higher number in red. So this person in red with a broad base, if we look at their central pressure, is much higher. So much more central organ damage or central organ pressure being felt as compared to the person in blue. Again, both of these patients would have a systolic of 144 and a diastolic of 90. So peripheral pulse pressure, peripheral blood pressure, peripheral diastolic pressure will not differentiate these at all. So then the question is, does it matter? Is central pressure important in understanding our cardiovascular risk? And the answer is yes. This meta-analysis reflects over 7,000 patients from randomized trials. And you can see that this is the line of identity. If it wasn't predictive, it would be on the line of identity, and the further the area under the curve is to the upward and to the left, this is sensitivity and 1 minus specificity, that the better a predictor it is. And the best predictive model we have is this curve here, which is central pressure, so central systolic blood pressure. So central systolic blood pressure is more predictive of congestive heart failure than brachial pressures. It's more predictive of heart disease, stroke, arterial stiffness, and we reflect that in my lab with coronary calcium scans and plaque in the coronaries, and in kidney disease, as we heard about already. It's also associated with both diabetes, and there's been some studies showing now cognitive dysfunction is greater in patients who have higher central pressure, so maybe affecting the brain in a more indirect way than overt stroke. We also have seen a number of randomized trials, and we'll hear more about this in the next lecture as well, that demonstrate that central pressure is more predictive of cardiovascular risk than brachial blood pressure. And that this magical number of 50, as we already heard, is critical. That's an easy breakpoint for all of us to use that's highly predictive of future events. Now this is the REASON study looking at LV mass. So this is looking at LV myocardial mass, obviously a very important process in hypertension as a sequelae that will lead ultimately to either arrhythmias or heart failure. Either of those, of course, lead to cardiovascular death in our patients. And while there was no difference in blood pressure control between perindopril, the combination of perindopril and indapamide compared to atenolol, there was no significant difference. There was a huge difference in central blood pressure. So we'll talk about the relative differences that these agents have on the central blood pressure preferentially compared to the peripheral blood pressure. Beta blockers have one of the least effects on central blood pressure, and that was reflected not only in change in central blood pressure, but that augmentation index got better with a combination of an ACE and diuretic as compared to a beta blocker, and LV mass got much better. So a huge decrease in left ventricular mass, LV hypertrophy and mass on this agent as compared to atenolol. So we're showing now that the reflection of central blood pressure correlates with organ damage. So it's not just a theory, it's not just a nice hypothesis. We are now seeing this evidenced in clinical trials where we see a differential effect on central blood pressure, which then has a direct differential effect on cardiovascular outcomes. We saw this slide already, the strong heart study, but I think it's a critical study to understand the one piece of the puzzle that explains why we're seeing differential outcomes. Central blood pressure, a number greater than 50, reflects a statistically significant increase. It's a 70% increase in cardiovascular risk. So among these 3,500 patients, there was a significant increased risk in cardiovascular outcomes. It's a hard outcome study as compared to normal less than 31 aortic pressures. There was a trend with hypertension, and we know hypertension, brachial artery hypertension, is certainly predictive of events, but it did not hit statistical significance. So this was at least twice as powerful a predictor of future events, knowing the central pressure as compared to the brachial. Since they're both done now with basically the potential of a blood pressure cuff, we can get a lot more information, predictive information, by using the central pressure. So we often see, again, as I showed earlier, patients with similar blood pressures. These are patients with identical blood pressures, 140 over 82, 140 over 80, both of them 65-year-old men, but one of them has a much broader abnormal appearance than the other. So we're going to look at a healthier person without that augmentation index, without that bump of reflected wave, as compared to somebody who has a broader base here and an augmentation index that puts them over that number of 50 millimeters of mercury. So this person is at higher risk than this person, even though this person has 2-point higher diastolic pressure. So again, the systolic and diastolic pressures that we see and from our blood pressure cuff don't adequately reflect the central damage that could be occurring in our patients. And I think this is the most important concept, is there is a remarkably differential effect on central blood pressure that is not always appreciated with brachial blood pressure. So in this study, we have a bunch of different agents. This is systolic pressure centrally falls more, up is falling. I had a hard time with this myself, but this is how they did it in the paper. So this is a better effect. The taller the bar, the larger the effect on the central pressure. This is the brachial pressure, the effect of an ACE inhibitor. This is the central pressure. So a differential effect. If we look at the pulse pressure, brachial pulse pressure fell with an ACE inhibitor a few points, fell by almost 10 points with centrally. Same dose, same person. So a much larger effect on a central pressure when we talk about ACE inhibitors. So angiotensin, we understand the benefits of this class, and we can see now one of the benefits clearly is reflected in the benefit over ACE inhibitors. Remember that Reason study showed perindopril had a much better effect than atenolol. The reason is not only does perindopril have a much more profound effect on central pressure, but beta blockers actually statistically have less effect on central pressure. So the beta blocker, compared to the ACE inhibitor, had exactly the same blood pressure lowering from our cuff. Exactly the same. Blood pressure lowering. Identical. Yet the benefit on the central pressure was 3 times larger ACE inhibitor versus beta blocker. So it's not surprising to me if I have a 3 times more profound central effect that I'm going to affect things positively, like LV mass in the Reason study or outcomes in the Strong Heart study. Right? This is going to make sense that differential agents have differential effects. Right? The Europeans a while ago now, the NICE guidelines for hypertension have already eliminated beta blockers as a first-line agent for hypertension, right? Beta blockers are now reserved for patients with tachycardias, heart failure, post-MI. We don't use beta blockers as first-line agents based on those guidelines, and we're still waiting for our new JNC guidelines. But ACE inhibitors, calcium channel blockers, diuretics have a much more profound effect on the central pressure compared to beta blockers. And I think this is one of the reasons why we've seen differential effects in outcome studies as well. There's a number of outcome studies out there now that have shown benefits of ARBs or ACEs over beta blockers when it comes to blood pressure control. So differential classes of drugs have differential effects on peripheral and central blood pressures. And even within the same drug class, we've seen some differences. So let's take a look at that. So this is a study showing very simply that as we lower central blood pressure, this is systolic, this is pulse pressure, as we lower central blood pressure, we positively influence LV mass. So we can improve LV, this is septal thickness, we can improve LV mass by lowering the central blood pressure, by lowering the central pulse pressure. That makes sense. This study showed, study of beta blocker versus beta blocker, that one was superior. This study looked at metoprolol, non-vasoactive beta blocker, versus nebivolol, a vasoactive beta blocker, and we saw a larger reduction in central pressures, in systolic pressures, in pulse pressures with the vasoactive nebivolol, and that was reflected back to a benefit in the myocardium. So the left ventricular hypertrophy change was more strongly associated with one agent over the other. Again, only reflected by central pressure, not by the peripheral cuff. So we have even within classes, we have some differences among our agents that are reflected back. So we can see again the natural evolution. We have a person in A, a young, healthy, normal person with a nice, rapid, no augmentation index, no bump that was described. Nice, normal, good diastolic filling, a lot of diastolic time for filling the coronaries, a very healthy waveform. B is somebody who's getting a little bit older. Blood pressure goes up. They not only have more peripheral blood pressure problems, but the central pressure goes up. And you can see the bump and the rise after the bump. The augmentation index goes from 0, there is no bump, to almost 40%. A very high number for augmentation index. This is going to start causing LV hypertrophy, which is obviously going to lead to problems downstream. As patients progress through the process of heart failure, we start seeing a reduction. As the heart weakens, we start seeing a reduction in all of the pressures, and the augmentation index even drops a little bit as it gets weaker. And of course, as you get a very weak heart, inability to have a rapid transmittal, we actually start losing our augmentation index completely. The augmentation index goes down to almost 0 as the heart is weak, so it doesn't generate that augmented blood pressure anymore. So we can even track the process through a disease state like heart failure and see the process and the clinical effects of the systolic dysfunction. So I'm going to conclude with just a couple case examples. These are the type of patients that I treat in my practice, and these are the ways that I use the data in my clinical practice. This is a 64-year-old man. He has hypertension. His systolic is 138. His diastolic is 70. So he's got mild hypertension. He's at some cardiovascular risk. He has cardiovascular risk factors. So I want to have a better handle on whether or not I should be aggressive. 138 over 70 is actually not a bad number. So should I just use diet and exercise? Should I get him a little salt restriction and have him exercise a little bit? Should I put him on an agent? Should I put him on multiple agents? I don't get enough information from 138 over 70. So we did the central pressure measurements, and his central pressure was quite high. Remember, 50 is a break point for high risk. He's at 56. So his central pressure reflects a high central pressure. So I'm now more concerned. He has that bump. He's got that augmentation index. His diastolic filling is less. It's a more rapid drop-off, which is less coronary filling. He's now at increased risk based on a single number, 56, a number I can't derive from a peripheral blood pressure. So very simple algorithm. I decide I'm going to treat him now. His pressure's too high, ACE and or calcium channel blocker. In this case, he ended up requiring both to get his blood pressure down to a normal number. And you can see that augmentation index has already started moving after 2 weeks. We've seen that central pressure, the pulse pressure, now dropping down into the 40 range, and the augmentation index dropping from 17 by half. So I'm already moving the right direction. We don't want to stop there, so we can continue to treat him and follow him, and over time you can see these numbers go down. So let's take a look at another patient. There's a younger patient, 41-year-old male. But his pressure's higher than the last case. His pressure's 142. Now his diastolic's a little bit lower, but his 142 systolic a little bit higher than the last guy. But when I measure his central pressure, he's below that threshold of 50. So he has a central pressure, an aortic pulse pressure of 44. His augmentation index, 0. He's got no early bump. So I'm not as concerned about the sequelae of his central pressure. Central pressure, he needs to have his pressure dropped a little bit. I'm not suggesting that we ignore 142. But his central pressure is low. I'm going to be less inclined to jump in there with pills, and I'm going to be more inclined to try lifestyle therapy. So I tried exercise. We talked to him about diet restriction, exercise, all of these things. Within 3 months, I had him come back, went from 44, a little bit elevated for his age and gender, but not over 50. He's now down to 37. His augmentation index is still 0. He's got no early bump. He doesn't have that reflected waveform that we see. So we can see improvement in the numbers, and now he's back in the normal range. His systolic is 124, his diastolic is 62, certainly does not need drug therapy. So it helps me choose which agents. I'm more likely to use ACE inhibitors or calcium channel blockers if I see a high, depending on the patient, a high central pressure, because I know they're more vasoactive and have more direct effect on central pressure. It helps me decide between treat or not to treat with drug therapy, another important decision we have. And as the risk of the patient goes up, I think we can be more and more educated as to which agent is appropriate for our complicated patients. Certainly I take care of a lot of dialysis patients, and they're obviously of the most complicated that I deal with in cardiovascular medicine, and certainly having a little more direction as to what drug I would use, what drug combination I would use, and looking at the effect of treatment, I think is just very important as a simple, non-invasive way to monitor patients' outcomes. So central blood pressure specifically, central systolic blood pressure and pulse pressure are better predictors of cardiovascular risk than just our blood pressure brachial measures. We sometimes don't see the brachial pressure, and as we'll see in a moment, and I think even a more dramatic study, the Ascot Cafe study, we're going to see that when blood pressures are equal, outcomes are different, and that can be largely or entirely explained by central blood pressure effects, that we can differentiate even among active treatments the potential benefit to our patient. So central pressure waveforms provide important information on targets for therapy, for the management of blood pressure, and reduction of cardiovascular risk. And I think that that's very informative. Again, non-invasive way to monitor our patients. Very simple, but I think very elegant to show improvement. Or if we're not improving, we can change our algorithm and our management. So I'll stop at this point, turn it over to Susan for the third part of the puzzle, and then we'll come back up for Q&A, I think in a little bit.